first guest is Dr. Arvind Bansal. See if I get this right. You're a pulmonary specialist, you're a critical care specialist, and you're a sleep specialist.
That is correct.
With Baptist Health Lexington. Welcome.
That is correct. Thank you. Thank you for having me.
Now, I said snoring and sleep apnea. Not everybody that snores has sleep apnea, but sleep apnea is a pretty big problem.
Yes, you are right. You are right in saying that snoring, not every snorer has sleep apnea, but snoring is one of the big risk factors for sleep apnea. So when we talk about sleep apnea is a sleep breathing disorder where repetitive closure of the upper airway occurs either partially or completely. It happens multiple times during the night, which leads to fragmented sleep, and that can lead to excessive sleepiness during the daytime and other comorbidities such as heart problems, strokes.
Now, when I trained, when I was not that I'm old, but as a younger physician, it was not heard of as sleep apnea. So it's a relatively rare diagnosis, but it does affect quite a few people.
Yes, it does. The estimates are that about 70 to 75% of adults are still undiagnosed. It is prevalent. It is present in 12% of adult U.S. males and about 5% of females. So it is pretty common. It affects all age groups. As we age, it affects more. Male gender is particularly more affected than the female gender. But after menopause, that kind of evens out, and both can have equal distribution of sleep apnea problem.
Well, so as myself as a physician or somebody's partner that notices a change in sleep habits, what are some things that you might think, okay, this sleep apnea might be a problem?
So some of the things which we look for as we talk about snoring, snoring is the number one. Most of the patients who come to us are brought on by their bed partners that my husband snores or my wife snores, they stop breathing, they gasp, they choke during sleep. And the other big problem is daytime fatigue and sleepiness is very common, and that can affect daytime productivity, for example. Then we also get referrals for patients who have uncontrolled high blood pressure, diabetes, heart rhythm problems, atrial fibrillation in particular. So a lot of those other sort of risk factors come in, which can be suggestive that there may be underlying sleep disorder breathing going on.
So if there's a concern for sleep apnea and somebody ends up in your clinic or your office, how do you make the diagnosis?
So history and physical is very important, as always in medicine. So first you need to have a proper history of the things we talked about. Then the physical exam findings are important as well. So it's about 70 to 80% of people who have sleep apnea, they are overweight or obese. Then we also talk about upper airway abnormalities, somebody with a thick neck. In males, we call it anything neck size over or collar size over 17 inches. In females, anything over 16 inches is a risk factor. And then there are certain facial abnormalities. If the chin is receded, that puts extra pressure on the breathing at night time. So once you see that this patient may have sleep apnea, then there are few ways you can diagnose them. The best way to diagnose is to get them in the sleep lab to do a sleep study, where we comprehensively evaluate their brain waves to look at how deep sleep they're getting, if they're getting into dream sleep, their oxygen levels, their heart rhythms, their breathing effort, and if they're stopping breathing or their breathing is getting shallow, their leg movement. So a lot of those things we monitor. And sometimes we pick up certain other unusual disorders which somebody is not expecting when we are seeing people sleep. We know that is cumbersome for people to sleep in a foreign environment with all the leads. So there are newer ways we are diagnosing now where it is done in the home setting, where people take a monitor home, which measure some of the things we talked about. It doesn't measure everything, but it does measure their breathing, their oxygen numbers, their heart rhythm, to see if they're having any events at night. And that determines if a person has sleep apnea or how severe it is. And then that also determines how we are going to treat it.
When you mentioned treatment, well, a lot of people have heard of CPAP, the things they wear on their head. That's one way, but there's other ways?
Yes. So the sleep apnea is that we don't have a fixed airway up here, so our soft palate, tongue, everything sort of comes together. And when people are sleeping, with the gravity, everything goes down, we relax our muscles, so things collapse. The CPAP is the gold standard. It works across all all severity of sleep apnea. It is basically pressure air to create an artificial airway so that person keeps on breathing in and out and doesn't get into some of the consequences of sleep apnea. Now, as you said, not everybody tolerates it because it's a mask, people are claustrophobic, some people just don't like something on their face, or sometimes pressure from the machine also bothers people's sleep. Then other treatment options are oral appliance therapy, which can be done through a dentist. So we talked about creating artificial airway in the back. Right. So with this, we are moving the lower jaw out where the tongue is getting pulled out and creating more space in the back. That is one therapy. Surgical treatment options are there, where a surgeon goes in and reconstruct the whole upper airway to help out with that. The new technique or new technology is a pacemaker therapy, where basically you have a hypoglossal nerve stimulator which can improve the airway.
So there's a lot of ways. So if you're a snorer, your partner thinks you have sleep apnea, you ought to see your physician. Thanks for the information, really great. We'll be right back.